Okay, very important topic for everyone sitting in this hall. Okay, very important topic. Okay, heart-lung interactions. Okay, this is a full question in the exams. A full question, don't write, I think you should probably just listen properly and understand what I'm talking. Okay, it's a lot of physiology that we're going to do, lot of physiology. Okay, a lot of physiology we're going to do, and I'll try to make it very interesting for you all so that you all understand it. Okay, so it's going to be physiology, more of physiology today now. Okay, more of physiology, but you have to know this physiology because that is how you're going to manage your patients. Okay, that's how it is. So heart-lung interactions, it's like a journey. You know, when you're putting a patient on the mechanical ventilator, it's like a journey. It's like a journey that goes on with the patient and the ventilator. And that, since you're putting something new, unless both of them interact properly, you're not going to get the ultimate optimum outcome. They have to together interact very beautifully. So the journey depends on both of them. Depends on how you ventilate and depends on how the heart reacts. Okay, how you ventilate means how the lung reacts and how the heart reacts. If you do not get a good interaction between them, the journey is not going to be extremely good. Alright. Mechanical ventilation, when you say mechanical ventilation, is a supportive therapy for the lungs. It is just a supportive therapy for the lungs. Okay, it is supportive therapy for the lungs. But this supportive therapy of the lungs has got huge implications of the heart. They've got huge implications of the heart. So it all depends on how mechanical ventilation moves the lungs to how it impacts the heart. That's how the entire thing is. Two things are there, very important, that you must understand here. Breathing actually needs an adequate cardiac output. So if you cannot breathe, if you are not having a good cardiac output, you cannot breathe well. It's as simple as that. Breathing requires an adequate cardiac output. It is a kind of a stress response. Okay, and importantly, when you breathe, there is going to be an increase in the preload and there is going to be a decrease in the afterload. These are two things that are going to occur. In all your patients, there is going to be definitely an increase in the preload and a decrease in the afterload. This is going to occur when you are breathing. This occurs to all of us. Okay, there is going to be increase in the preload. Why? Your breathing venous return is actually going, you are having increased negative pressure, it is going inside, that's why you're increasing your preload and decreasing your afterload. There are two things that are occurring over here. Okay, breathing requires adequate cardiac output. This is very important. Now, it's like a stress test. Breathing, okay. It's like a stress test. What is the stress test? You create a kind of stress in the body and you see whether the heart is failing or not failing. That is a stress test. This is what happens. When you go for a stress test, what really is occurring is, this person is running on a treadmill. They put the ECG leads. They see whether there is ischemia is occurring. If there is ischemia that is occurring, it is positive. That is what a stress test is. Similarly, mechanical ventilation is also a stress test. Mechanical ventilation is also a stress test for every patient of yours, and you can get loads of information when you do mechanical ventilation. Okay, I'm just very much interested in mechanical ventilation. As I'm I go to the basics if you see with mechanical ventilation. Alright. So this study was done long ago, it's 20 years back, this study. So what it is saying, the study is gastric mucosal pH and blood flow. What they do, they actually are monitoring gastric mucosal pH. There is a device called as gastric tonometry. Gastric tonometry. In gastric tonometry, it's like one of our catheters that goes inside our eyes tube and actually takes the pH. And that pH is usually called as PHI. Okay, gastric tonometry. And they were monitoring blood flow. Okay, which is via a technique called as laser Doppler flowmetry. It's called as laser Doppler flowmetry. Right? So they were doing that in these patients of COPD. Okay, these are patients of COPD and they monitored them during their weaning trials. Okay, they monitored during their weaning trials. So there was weaning happening. Now see, this is their weaning trial. Weaning trial is for 2 hours. Classically, weaning trial is for 2 hours. 30 minutes equals to 2 hours. So this is hour 0 and hour 120. That is 0 hours and 2 hours. Okay, this is 0 hours and 2 hours. The green ones are the ones that weaned off, and the black ones are the ones that didn't wean off patients. Okay, now look at the ones that this is the respiratory frequency went up. That is the classical definition of weaning failure. Then the RR goes up. Similarly, when the tidal volume goes down. So the black bars are where the patient failed to wean. The patients failed to wean here. Clear on this? Are we clear? So when they looked at the pH of these patients, normal ABG, when they looked at ABG of these patients, what they found was those patients who actually failed weaning, had a drop of pH that was much higher than otherwise. There's a drop of pH. And there was an even big drop in the PHI, the gastric tonometry device. There's even big drops. If you look at this, 7.45 to 7.3, 7.38 to 7.29 on those who actually failed weaning. Okay, that means the pH is dropping in those patients who are failing weaning. Now, if the pH is dropping, that means something locally is occurring over there. Which is some pura body ka hai. But if there is something happening down there, means locally something is occurring there, which is causing the pH to go down. Are you understanding? Gastric tonometry pH going down means there is something wrong occurring in the mucosa of the gastric system, which is dropping the pH. Clear on this? So what is that? So they looked at the cardiac index of this particular patient. They thought maybe it's the cardiac index causing a problem, causing a reduction in the flow, causing the pH to go down. So they looked at cardiac index. So if you look at cardiac index, these are the patients who weaned. These are the patients who weaned off. The green one is the one that weaned off. Okay. So when they weaned off, you see the cardiac index, how they were compared to those that were not weaning. What happened to the cardiac index? Actually went up. Cardiac index went up. What is cardiac index? Heart rate is there in the cardiac index, isn't it? Heart rate into stroke volume divided by body surface area. So the heart rate is going up or the stroke volume is going up. Now the question is, what is going up? Is it the heart rate or is it the stroke volume? Because they both are contributing to the cardiac output, right? So if the stroke volume is going up, what is going to happen? The flow will probably increase. Okay, so what did they look? They looked at the flows by laser Doppler flowmetry. They are looking at the blood flows. So what they found is the blood flow in the gastric mucosa in those patients who weaned off, who did well, actually is looking like it is going up. Can you see this? It's going up. This means to say that there is some improvement in mucosal perfusion when the patient is actually weaning off. In those patients who don't wean off, the mucosal perfusion actually goes low. Okay, isn't that the principle of a stress test? This is exactly the principle of a stress test, isn't it? What happens in a stress test? The stress test is when the patient is going into an exertional phase, the coronaries are unable to give the amount of blood supply. Exactly. This is exactly what is happening in the weaning phase, like a stress test. You're going from normal ventilation to weaning, and what is happening? The blood flow, when it is going down, the patient is actually not able to wean. Clear? The blood flow is going down, it means the patient is unable to wean. You're understanding this?
So as the cardiac index increases, so the
heart rate and stroke volume.
Supposed to increase.
Exactly, it's not. That's why when they did it, they found out no, it's not.
It is reversed.
That's what they're saying. So what they're saying is the gastric flow actually came down. Okay, gastric blood flow comes down in those patients who don't wean. Okay, so it's like a stress test. It's like a stress test. Now it can't be just one place. No, it is all over the body. So what they have proven now, here if you are weaning, that is going from mechanical ventilation to weaning, it is a stress. It is a big stress. And those patients who get weaned off successfully, means they are those patients whose flow is increasing, whose blood flow is increasing. Clear? This is what is very clear here. What is very clear? So now you can imagine in your patients, for example, bed number 1 there. Okay, that patient could he have weaned without giving high dose NTG, without Ismalol, without all these things. We did all those things on that patient so that we could wean this patient from the situation that he was in to come off. Otherwise, he was failing weaning trials, isn't it? He was failing weaning trials. 3 weaning trials he failed. He gave high dose NTG, optimize the cardiac index, optimize the cardiac output. That is when the patient weaned off. So it's a stress test. Why was the patient weaning? He was weaning because of the fact that he was not tolerating the stress. He was not tolerating. Heart was not improving cardiac output. Heart was not doing that. So what we had to do? Reduce preload in some way. Once you reduce the preload in some way, because he is a patient of low ejection fraction, he kind of improved. We put the diuresis out, afterload improved. Right? That's what we did. Now this is another very similar study. Now, जैसे कि the most important cardiac output monitor that you can have is mixed venous oxygen. We never described it there. So mixed venous oxygen is one of the most simplest parameter you can do to actually judge cardiac output. That is, you put a swan gans, and at the tip from the swan gans you take a mixed venous oxygen that mirrors the cardiac output. Clear? So what do they do here? They actually look again at weaning again. Okay. And what do they find? They looked at mixed venous oxygen saturation. Okay. Those patients who weaned are these open bars. Okay. Those patients who weaned, they are these open bars. They weaned off, that means the mixed venous oxygen saturation on the y-axis remained the same, compared to those patients who didn't wean off. Those patients who didn't wean off actually went down on the mixed venous oxygen saturation. What does it again indicate? Decrease in flow, decrease in cardiac output. Very important. Very important. Cardiac output is coming down. So if your patient already has reduced ejection fraction, and now you go ahead and put this and try to wean this patient off, there is going to be a stress response, and these patients may decompensate. You understand? This is very important. So when you're doing a weaning trial, we come to all these conditions to understand whether what I have to optimize so that it takes the stress. Are you understanding? You understanding here? Now look at this other. These are 19 adults. Okay, these are 19 adults who basically 16 males and 3 females who failed and succeeded one breathing trial. Look at this. What is happening over here? This is called as an isopleth. Okay. Now the open bars. Understand this very clearly. Okay. Here you have oxygen transport, delivery of oxygen. Whereas here you have consumption of oxygen. You have consumption of oxygen. Now look, something what interesting is happening here. So when the patient is actually getting onto a spontaneous breathing trial, in those patients who are successfully weaning, what is happening? His oxygen transport is actually improving and his oxygen consumption is increasing. Both. It's not just the delivery of oxygen. There is also a delivery of oxygen that is going, and the red blood cell is able to take that oxygen much better and help the patient. You understanding? Both are occurring. It is not only the delivery, it is also the oxygen has been taken up well. Are you understanding? It is the other way around for those patients who are not weaning. There is some sort of improvement in delivery, very small improvement in delivery. See this? From here to here this was. The delivery is very small increase, very small improvement in oxygen transport. However, how does he maintain if that is the case? He is somehow maintaining because the extraction or consumption goes up majorly. The consumption of oxygen majorly goes up. So you understanding? This is what is occurring. Okay, so these are physiology principles that are occurring. Okay, how is he still managing if itna cardiac output drop ho raha hai? His consumption is increasing. He is extracting more. So somehow he is tolerating the weaning trial. Are you understanding? So delivery is one part of the story. He also has to extract the oxygen, right? So when you are delivering, the body has to extract, right? So in normal circumstances, you are delivering well, you are extracting well. In abnormal circumstances, when the heart is unable to take, it is delivering less but extracting more to somehow getting more oxygen, getting the required oxygen. समझ में आ रहा है? It's the extraction that is changing. समझ में आ रहा है? So heart-lung interaction unveils how much stress the heart can take. That is the answer to this. So tomorrow when you are doing a weaning trial, be very, very careful. Be very, very careful doing a weaning trial. Please don't put on weaning trial and just move out. It doesn't make sense only. It doesn't make sense. You have to see how the patient is weaning well. Okay, when you are weaning a patient, especially now, this is so important when you have heart failure patients. Isn't it? It is so important when you look at heart failure patients if you now think of a weaning trial. Are you understanding? You can't just go and wean a patient. You can't just put a patient on. It's not an OT patient. It's not an operation theatre patient. It's a critical care patient. Okay, it's a big difference between OT patient. OT patient, you can close your eyes and wean the patient. Okay, because they are essentially healthy people who have come for surgeries. Right? But if you're looking at ICU patients, these are those patients in which already the delivery of oxygen is a problem. There are patients in which already the extraction is a problem. In critically ill patients, the delivery also is a problem. In critically ill patients, because of mitochondrial failure, even the extraction is a problem. Are you understanding? Even the extraction is a problem. So mitochondrial failure, which is in sepsis, for example, the delivery is also down, but the extraction also is bad. So that graph doesn't work like how we just now showed. Clear? So there is a problem. So in the stress test. Now, the first interaction that you must understand when you think of heart-lung interaction is autonomic nervous system. The first blood pressure drop that occurs, after you intubate your patient, the first blood pressure drop after you intubate a patient is because of the autonomic nervous system. Now what is that? That is called as the inflation hypotension reflex, inflation dilation reflex. You'll miss all these things. So inflation dilation reflex. Clear on this? Inflation vasodilation reflex. So the first heart-lung interaction. So first BP drop or a drop in cardiac index is due to autonomic nervous system working suddenly. Got the point? So let us see this experiment. Okay, this is an experiment. Now If first you would initially think that the first thing that is occurring is probably because I ventilated the lung, the venous return is reducing and the blood pressure is dropping. That is what you will think first. No, but it is not. That is not the first reflex. The first reflex coming into play is this reflex. And to identify whether it is this reflex, what do? They actually put a pair of dog on bypass. बात बोला ना क्या? ठीक है. बोला मेरे को बोला नहीं. Okay. Just hold on now.
Yes.
So the first drop in BP is mediated by autonomic nervous system. Okay, or first drop in BP. That is what you must understand. Okay. So let us understand this. Okay. Now this is all physiology. Okay, but this will help you to understand pathology. If you don't understand physiology, pathology you will never understand. Okay. So initially we did say that the fact that when you're putting on a from weaning mode to spontaneous mode, from control mode to spontaneous mode, there is going to be a cardiac, there's going to be a stress test. It's going to be like a stress test. Patients can decompensate. That we realize this. And those patients who actually are not able to wean off, they are probably decompensating, right? This is what we know. What we also should understand is the first drop in blood pressure. For example, this patient, if you intubate, the drop in blood pressure would be related to the autonomic nervous system. Now see, how do I understand this? Initially our thinking was venous return, right? But that is not the situation. The situation is like this. If you take this patient off the complete venous system, if you take the patient off the venous system, you put the patient on bypass. That means he's off. There is no heart, it's only the circulation that is happening. It's the circulation happening outside. So whatever is happening outside. So venous return cannot change because we are doing it from outside. Clear on this? Huh? So what do? They put these dogs on a bypass machine. And then they went on to ventilation. So what they found, they inflated the lungs to 20 millimeters of positive pressure after they have taken the patient on a bypass machine. And then the pulmonary stress disturbance actually gets inflated. Once that gets inflated, the somatic nerves causes a depressor reflex. The entire body, the lungs are filled with nerve endings. They originate in the thorax, pass through the thorax and end in the thorax. Okay, these are very intricate, complex neural networks that are there inside the lungs. Okay, and what happens over here is the fact that the moment you inflate, there is the stretch receptors that get inflated, which actually causes this depressor reflex. And this is exactly what you're seeing over here. This is hind limb, this is perfusion. On the back, they're looking at the perfusion of the dog, okay? And what is happening is the moment they have inflated, see what is happening, there is a super drop in the perfusion. So what does this mean? In a bypass patient, if there is going to be a drop in blood pressure, patient on bypass, then it is not related to venous return. This is completely isolated. So this is probably related to the significant negative inotropic and chronotropic effect on the heart, which is because of the ANS, because of the autonomic nervous system. You understand this? So what I am trying to tell you is the first drop is because of autonomy. So this is the second interaction that I just told you. The first interaction was what happens when weaning happens. Okay. The second heart-lung interaction that I have talked to you is about the autonomic nervous system. Alright, this means to say the autonomic nervous system has an important role to play. So this is very important. So if you have dysautonomia, the patient is on a brainstem related issue, he's a brain dead patient, or he's having sympathetic storming, he's got a head injury, dysautonomia can cause more problems. It can cause these issues to go haywire. You understand? Because it doesn't need venous return here. अपने आप ही वो हो जाएगा उसका. ठीक है? Now let's go to the very important part. And this is a part that you'll be asked 100 times in the exams. Okay? Pulmonary vascular resistance. What happens to the pulmonary vascular resistance? Okay? Let's understand this. So first concept you must understand is about, many of the anesthetists will know the concept called as hypoxic pulmonary vasoconstriction. Now what is the hypoxic pulmonary vasoconstriction? If you have a patient who's mnemonic, who's having ARDS, something like that, there is going to be an alveoli that is full of hypoxia. It's full of hypoxia, right? That is, there is no oxygen going through. So because there is no oxygen going through, what is the body's defense mechanism? Is to vasoconstrict, is to get that circulation to be small. So that circulation actually becomes small. Okay, that is what is happening. This is hypoxic pulmonary vasoconstriction. This is a defense mechanism to improve the VQ mismatch, to reduce the dead space. Because in this case, if I would actually have a hypoxic kind of condition, the patient will not do well, basically. Okay, it will be all non-oxygenated blood going everywhere. You need this to be diverted from here to the proper alveoli. You need this blood to be diverted to the proper alveoli. That is why hypoxic pulmonary vasoconstriction occurs in the first place. Now, what have you done during ventilation? You have actually put this patient on a ventilator. When you put the patient on a ventilator, what actually happens? The oxygenation improves. It's going to occur. No? You're pushing air. If you're going to push air along with oxygen, it is going to happen. So you push air, oxygenation, and that alveoli will suddenly that vessel will actually dilate. This is a release of hypoxic pulmonary vasoconstriction that may occur. Now all the deoxygenated blood from here is now rushing into the others. All the deoxygenation blood is rushing into the others, causing a drop in oxygenation. Clear? So this can occur at that time. Okay. So this is a concept of hypoxic pulmonary vasoconstriction, right? So deoxygenated blood moving into the oxygenated side because of release of hypoxic pulmonary vasoconstriction. Okay, that is also causing the pulmonary vasodilatation. Right. Now a very, very important concept. Okay. So what I'm showing over here is an alveolus. And what you're seeing here, the vessels over here are called as alveolar vessels. What are they called as? Okay, the alveolar vessels. Now what you're seeing over here are depicted as extra alveolar vessels. These are vessels that are not around the alveoli, but they are around in the lung, but not around the alveoli. Right? Now, alveolar vessels, when you have alveolar vessels, what is going to happen is, when there is going to be pressure in the alveolus, by meaning PEEP, or by oxygen, or by ventilation, ventilation, or by PEEP, there is going to be a pressure. What will this pressure do? It will compress this. It will compress this. Those vessels will become small. The alveolar vessels are going to become tiny and vasoconstricted. But the extra alveolar vessels actually inflate when there is going to be a stretch of the lungs. The extracellular vessels. So the extracellular vessels are going to actually stretch. Okay. But the combined effect of all of these things is called as pulmonary vascular resistance. So there is a combined complex interaction of the extracellular vessels and the interalveolar vessels, which together gives you the pulmonary vascular resistance. Clear on this concept?
Why they stretch?
So these receptors, these extracellular vessels are actually not closer to the alveolus. They are subjected to the traction force of the main airways and the higher bronchi, not the alveolus. So the stretch of that actually opens that. You understand? So the combined effect cannot be judged by just looking at one thing. You understand? So got this clear? Till now this concept is clear? कि क्या हो रहा है?
What is the role of that?
कौन सा? How is your oxygen going from alveolus to your body? Through those vessels. These are the capillaries. You understand? The maximum amount of pulmonary vascular resistance that is coming from your capillaries. That you must remember. These extracellular vessels are also a different set of vessels. So they're opposite. They both work opposite. Okay, one dilates whereas the other constricts. So the combined effect of that will be your effective pulmonary vascular resistance. So what is the combined effect? The question is, what is the combined effect? If inflation is going to cause my alveolar vessels to constrict and my extracellular vessels to dilate, what is the combined effect on the pulmonary vascular resistance, on the whole thing? What really occurs is at the start. So this is your lung volume here, and this is your pulmonary vascular resistance. So what happens as a result of all this is, when the lung volumes are small, that is the patient is collapsed or something like that is occurring. Okay, this is where the pulmonary vascular resistance is lying. As you inflate the lung, you are going to act upon the alveolar vessels. As you inflate the lung, you are going to act on the alveolar vessels. So the PVR is actually going down a little bit, because at the same time the extra alveolar vessels is opening up. Okay, but if you keep on inflating it, as I told you, the maximum pressure is coming from the alveolar capillaries. As you keep on inflating it, there is going to be extreme vasoconstriction, which is going to cause your pulmonary vascular resistance to go up. Very important statement. You understand? Once more. So, what are we looking at here? We are looking at, you understood this concept? The intracellular vessels, extracellular vessels. Sir, को ना कल क्रैश हो गया, सर ने फोन किया था. Sir, you understood this concept? The concept of intracellular, extracellular vessels. You understood the concept? Now, what is going to happen is, if the lungs are small, if the alveolus is small, let's take the example of an alveolus, it is small. So what if the alveolus is small? This is not getting pushed that much. So your pulmonary vascular resistance remains at this level, for example. as you are inflating the alveolus, the combined effect of this and this comes in, which actually causes the pulmonary vascular resistance to go down. Combined effect. Now you inflate it more. I was telling you that the maximum PVR is contributed by the capillaries, alveolar capillaries. So you are actually pushing the alveolar capillaries so much that your pulmonary vascular resistance actually increases maximally. Clear?
So now what happens to extravalvular vessels?
So that doesn't contribute as much as capillary vessels.
So they remain dilated?
They remain dilated, but the combined effect of both, because of the extra effect of the alveolar capillaries, is the increase in the pulmonary vascular resistance. This is what the concept you must understand. I was teaching someone the other day. I was telling, I'll teach you what happens with PVU. I was teaching them. This is what happens.
So sir, the oxygenation also plays a role. No?
Sorry?
Sir, is that oxygenation also?
Yeah, so that is only a concept. That is the concept, but this is what actually happens in the body. Okay, what actually happens in the body, right? So in short, what is happening is over distension. So what you must understand as doctors now is that if you do over distension by increasing tidal volumes, or by increasing high peeps, or by doing high peeps, which is not warranted, or you increase minute ventilation. So what have you done? You have oxygenation, you have changed, you have distended the alveoli, or you have increased pressure on the alveolar capillaries. You are going to have an increase in the PVR. You are going to have an increase in the pulmonary vascular resistance, and your right heart will not be able to take that. You understand? Your right heart will not be able to take that. You got the point? Alright, so this is what is occurring at that stage. Okay, yes, PVR varies significantly at extremes of tidal volume and pressures. So now we have the third interaction that I've just taught to you. Okay, we started by saying about heart-lung weaning, then we talked about heart-lung autonomic nervous system, and now heart-lung PVR. Now let us see the effect on venous return. Till now we just talked about pulmonary vascular resistance. We will come to the clinical implications of all of those. We have talked about autonomic nervous system, we talked about the rest, and now we're talking about venous return, which you will know, but I will make you explain this better. Alright, now let's see. Your heart is inside the body. Okay, if I take this, how does this, is this a pressure chamber? The heart itself is a pressure chamber, which is actually inside a pressure chamber. The heart is actually a pressure chamber within the thorax. Within the thorax. So the vessels inside are under pressure from outside as well as inside. The vessels are going to alter from inside as well as from outside. That's the beauty of the heart. You know, it's completely by the vessels. The vessels are going to be altered by both the sides. So let's take it out. Okay, what is exactly happening in the heart? So you have a venous return that is there. A venous return that goes into the heart. Now what is this venous return? This venous return is actually all the blood that is lying in your capillaries. All the blood that is lying in your capillaries is the venous return. In your capillaries, the venous capillaries all across your body. So venous bed is very big. So it's the capillary bed. The capillary bed is very big. And that venous return pressure is also called as mean systemic filling pressure. It's also called as mean systemic filling pressure. Mean systemic capillary filling pressure. Okay, that's what it's called as. And this is that goes inside the heart, and then it goes around the ventricles and comes out as left ventricular ejection fraction. Clear? This concept is clear? So this is mean systemic circulatory filling pressure. Clear on this? Clear? This is exactly what happens when you are going to give vasopressin to your patients on in cardiac arrest or adrenaline. When you are giving adrenaline to your patient on cardiac arrest, the mean capillary filling pressure is actually constricting and sending all the blood from the capillaries, which is a large bed, into the heart. It's not the heart contracting because of adrenaline. Clear on this now? Whereas the LVEF will actually go higher and higher or depending on the afterload. We discussed this. It will actually have an effect because the afterload is not good enough. If afterload is too much, LVEF will also go down. So in short, external things away from the intrathoracic pressure. External things away from the we just now said pressure in pressure, right? Pressure chamber in pressure chamber. Your IT, that is your intrathoracic pressure, does not have an effect on the venous return. Per se, because the amount of blood going from outside to inside depends on mean systemic filling pressure. Okay, now we'll come to that. It was slightly confusing. Whereas LVEF will change irrespective of your mechanical ventilation. You increase your afterload, you increase large amount of noradrenaline, the EF will actually go down. It can change like that. So there are two other parameters that will alter your venous return apart from intrathoracic pressure. Clear on this? Clear? Now how does blood rush from outside to inside? If that is the case, how does blood rush from outside to inside? It rushes from outside to inside when the right atrial pressure is lesser than the intrathoracic pressure. Right? Here the pressure has to be less. If the pressure is here less, blood will rush from outside to inside. Clear on this? Right atrial pressure minus intrathoracic pressure is your RV filling pressure. Clear? And your LV filling pressure is arterial pressure. That is this pressure minus, that is left ventricular, so pulmonary artery pressure minus the ITP. Clear? Now these are some concepts. So this is not the same with the pulmonary circulation. The pulmonary circulation is completely inside. Okay, left atrial pressure, I say entire circulation is within the thorax. So we'll come to what all this is. What the important thing that from all this you must understand is systemic circulation. Systemic circulation can be profoundly altered by ITP, whereas pulmonary circulation is usually immune unless lung volumes also change. So if I don't ventilate my patients, my pulmonary circulation will not have a problem, but I can still alter my systemic circulation. Are you understanding? Samajh mein aa raha hai the answer to this? Clear? This is physiology. Okay, it's all physiology. Right, now let's go to this curve. Very important curve. Okay. So, to explain this curve to you, what you have on the y-axis is blood flow. What you are having on x-axis is right atrial pressure. Okay. And what you are seeing over here is, this is the venous return curve. This one is your venous return curve and this is the LV function curve. So, in short, as your RE pressure is going up, the cardiac output of blood flow is improving. As your venous return is increasing, the blood flow is increasing. As the venous return is increasing, the blood flow is increasing till it reaches a vascular waterfall, beyond which there will be no improvement. What is a vascular waterfall? तुम्हारा venous return बढ़ रहा है because outside pressure to inside pressure change हो रहा है. लेकिन एक टाइम आएगा कि वो पूरा collapse हो गया. Collapse हो गया तुम कितना भी pressure यहाँ से दो अंदर घुसेगा नहीं वो. इधर पूरा मेरा collapse अगर हो गया, whatever I am going to give from outside is not going to enter inside. That's called the vascular waterfall. You understanding this concept? Understood this concept? So as you are increasing venous return, the cardiac function is going to improve, but there will be a point beyond which इतना negative pressure create हो रहा है, लेकिन फिर भी no water is going to go inside or no blood is going to go inside because it has reached the vascular waterfall. So even after increasing my venous pressure from here, my cardiac output will not improve. Clear on this? So there is a limit to venous return. That's what it means. Sanjana, she was a shipper. Clear? So this is where a cardiac output is. It is a combination of the adequate venous return and the adequate cardiac function. That is where your cardiac output is. Your function also has to be good. Your venous return also has to be good. That is when your cardiac output will be fair enough. That is normal. Clear on this? Now let's take the example of spontaneous breathing. Now in spontaneous breathing, what is happening? There is a drop in the pleural pressure. First thing, intrathoracic pressure, there is going to be a drop. The drop in pleural pressure will drop the CVP. Okay, the drop in CVP will increase the venous return. Okay, because it is negative pressure, so obviously venous return will start moving. So venous return starts increasing. That venous return will cause the right atrium to get filled up. The right atrial pressure will go up. Along with that, the stroke volume will go up. Clear on this? Clear? Clear what's happening? So this is what is occurring on the graph. On the graph, what is happening? The venous return is further increasing. Okay, because you see the venous return increasing. So venous return is increasing, that means it is going higher than this. It may reach the vascular waterfall. Okay, but cardiac function curve is also going up because of that. Stroke volume is going up, blood flow is going up. But it cannot go beyond this because vascular waterfall पहुंच गया है. समझ में आ रहा है? So this is how the cardiac function curve is moving. So you cannot keep giving fluid again and again and again and again because you cannot keep making negative pressure again and again and you cannot keep increasing. That's what I'm trying to tell. So cardiac output is gone up. Okay, this is how cardiac output is going up. Right? Now what happens in IPPV? In IPPV the exact opposite occurs, right? The exact opposite. Pleural pressure is going to go up. The CVP is thus going to go up. There is going to be a drop in the venous return. There is going to be a drop in the right atrial pressure. And there is going to be a drop in the stroke volume. This is what is going to happen. So where will the curve go? Now here what is happening to the venous return? It is going down. It is going down. So it has to come back from here to here somewhere, right? So this is what is occurring. This is what is occurring. So once you put the patient on mechanical ventilation from spontaneous to this, what is happening? The cardiac function is actually going a little bit haywire. Okay, it is going down slightly Is going down slightly, and that may contribute to the drop in blood pressure. Okay, that will contribute to drop in blood pressure. What do you do in these cases when it goes down? When your patient is on the ventilator, you're about to intubate your patient, and the blood pressure goes down. What is the first thing you normally do? Fluid. You give fluid. This is exactly what you do. Okay. The moment you have a drop in the blood pressure, you start giving fluid. But here the cardiac output is on the lower side. Remember this. Okay. To combat this, so if I want to go back, so take the example of a patient that you have actually gone from spontaneous to IPPV. What does it do? It drops the cardiac output. From spontaneous to IPPV, it drops the cardiac output. You end up giving venous return by giving fluid. What do? You give venous return by increasing the fluid. So to combat this, you are now giving fluid. So what happens to the venous return curve? It moves this way. You understand? Venous return curve is moved. Your cardiac function has remained the same. Your venous return has gone up. Essentially in the body now, there is more fluid than is what is required. There is more fluid than what is required. So this is the huge amount of fluid that is required. Now, I move this patient, when I move this patient, now I want to wean this patient. Say after some days or evening I want to wean this patient. Where is that fluid gone? That fluid is extra fluid. It is lying inside the body. And now if I start weaning this patient with that extra fluid, what is going to happen? See, now the cardiac output is improved, venous return is improved. You have done well. By giving venous return, you have improved cardiac output. So the BP has become better. But this extra amount of fluid that is lying over here is a problem for me. So if I convert from IPPV to spontaneous ventilation as in weaning, what is going to happen? All this fluid will now become fluid overload. You understand? The cardiac function, actually blood flow curve has come to the left. You see this? It has come to the left. And this patient will actually decompensate. That is the reason that when we are weaning our patient should be in. That is why if you wean our patient should be in negative balance. So it's very essential before you wean the patient, look how much cumulative positive balance is, how much negative balance, because we know that if you keep them in negative balance, they can be weaned off better. Because you understood this curve now? You understood what's happening? You understood what's happening? Okay. Now so that's the concept of ventricular venous return. Now we are coming to a concept of transmural pressure. Okay, we were discussing about cardiogenic shock as to how this can improve, how ventilation will improve cardiac output. Our entire result in cardiogenic shock was how to improve the cardiac output. That was the first thing that we were thinking, right? So how do I improve my cardiac output? So let's take the example of the lung. Okay, now the lung has inside pressure. What is the inside pressure? The inside pressure is what? The alveolar pressure or the heart pressure. This is the heart pressure. The heart is the pressure. Outside pressure is the pleural pressure. Outside pressure is the pleural pressure. Right? Outside pressure is the pleural pressure. Any transmural pressure anywhere is inside pressure minus outside pressure. And when you consider the heart, that is equal to the afterload. The transmural pressure of the heart reflects the afterload. Inside pressure minus outside pressure. Inside pressure minus outside pressure. Clear? That is the afterload. So let us take the example of an alveolus. Okay, we are taking the alveolus now. And now you give high PEEP to this alveolus. If you give high PEEP to this alveolus, what is really going to occur? There is going to be an increased PVR. We discussed that. We discussed there is going to be an increased PVR. We said the PVR curve goes up, pulmonary stress is going to go up, and that is going to reduce your right ventricular ejection fraction because it cannot fight against the right ventricle. We discussed that. But what is also going to occur in this case is that there is going to be a reduced transmural pressure. It is going to reduce the transmural pressure because outside pressure is your PEEP. Outside pressure is your PEEP. So inside pressure minus outside pressure, this equation will reduce. This formula will reduce. Outside pressure ज़्यादा हो रहा है इधर. So what is going to happen here after load? It's coming down. It's coming down. That is the principle of your NIV. That is the principle of your NIV. Clear on this? Clear on this? This is the principle of your NIV.
Can you repeat?
So your afterload is inside pressure minus outside pressure. What is the afterload? Inside pressure minus outside pressure is the transmural pressure, right? Now, when I am giving non-invasive ventilation, non-invasive ventilation, my outside pressure is increasing. This is inside pressure minus outside pressure, right? So, if I am going to give a PEEP, that is by NIV or by ventilation, what am I doing? I am actually increasing the outside pressure. if I am going to increase my outside pressure, the overall equation here is coming down. Inside pressure minus outside pressure. That means the LV after load is coming down. Got the point? And the LV after load coming down will help to improve such cases of cardiogenic shock, because once the after load comes down, the heart can contract much better. After load is after all there, it is preventing the heart from contracting. Well, you understand? So, just like how we discover PVR, there are complex interactions. This is the complex interaction. If you increase it too much, the PVR is going to go up. But I have to combat it in such a way that my afterload improves. That's why the echo or a cardiac monitoring becomes very important. ये करने के बाद क्या हुआ? And titrate accordingly. You understand? मेरे पीप बढ़ा तो क्या हुआ? अगर पीप बढ़ा के पेशेंट ठीक हो रहा है, मतलब वो ऑप्टिमल पीप जैसा हो गया. You know, because BP is improving. You might always think PEEP actually drops the blood pressure. No, PEEP can improve blood pressure because it is improving the afterload. समझ में आ रहा है? Clear? Now let's go to another concept. This concept is also very important. It's called ventricular interdependence. So the systolic function of the LV causes 20 to 40% of RV systolic pressure also. Whereas RV contraction contributes to 4 to 10% of LV contraction. This is an interdependence. This is something you must know, that it is not, if LV is contracting, it doesn't mean LV is only contracting. It also making the RV contract. So if the RV is contracting, it also doesn't mean that the RV is contracting on its own. It's also helping the LV to contract. So one depends on the other a little bit. So one failing each other is also going to be not good. You can't say I got isolated LV failure. This isolated LV failure is going to cause the RV also to fail. Are you understanding? This is what I'm trying to say. Ventricular interdependence. Okay. So, for example, this is a cut section. And why does this occur? Because LV and the RV, they are inside one cavity called as the pericardium. They are inside one cavity called the pericardium. That is why one will depend on the other. That is why both may work in systolic and diastolic. So systolic functions are definitely dependent on each other. Can you see this now? Understood this? Systolic functions are dependent. So this is important for you to understand, because you may not say isolated LV failure. There is always going to be some RV failure. You cannot say isolated RV failure. There is going to be some LV failure also. Some dysfunction are going to occur interdependence. So that means systolic functions are going haywire. Right? Now look at ventricular interdependence in a different way. Okay. Now this is increase in RV after load. When you are ventilating your patient, there is going to be increase in RV. For some reason, increase in RV after load, PVR increase. If that is going to occur, there is going to be a shift of the septum to the left. There will be a shift of the septum to the left, because afterload is increasing. Right? If you take this as my LV and this as my RV, or this as my LV and this as my RV, if by any chance there is going to be an increase in the afterload because of the PEEP that I gave, because of the way I am ventilating, because I am not doing the right thing the right time, I am over-distending, I am doing something like that, PVR is going up, my afterload here is increasing. If my afterload is increasing, the pressure here is increasing. The pressure here increasing will actually move the septum to the left. It will move the septum to the right or the left, whatever if it is RV or LV, right? And that will cause the ejection fraction to actually LV filling to come down, because there is no more space. This is the phenomenon that occurs with pulmonary embolism. In pulmonary embolism, what is happening? There is going to be an increase in afterload. The entire RV cannot pump out. This is exactly what's happening when there is going to be increased PVR, increased pulmonary vascular resistance. RV cannot pump out. Right? This will actually dilate. Since it dilates, this will move to the left. Since it's moving to the left, filling will reduce. Simple, filling will reduce. So this means to say, even diastolic functions get affected. It's not only systolic functions, it's also diastolic functions that get affected when you are actually in ventricular interdependence. Right? So spontaneous respiration or mechanical ventilation exacerbates this problem. This is going to occur otherwise. But spontaneous respiration or mechanical ventilation will exacerbate the problem. ये जो interdependence का है ना, it will exacerbate that. This you must remember. Okay. So what are the clinical implications of knowing all these things? We understood all of these things now. We understood this very clearly. What is PVR? What is the autonomic dysfunction? What is happening? All these things. Clinical implications. So if you look at it, this is your ARDS protocol card. All of you should know this by heart. Pinpoint. Okay. Pit pad it should be there. So this ARDS protocol card actually has a lot of changes. Now if you look at these changes, that your changing, the mode is going from pressure control to volume control, the tidal volume increasing by 1 ml, you are reaching 6 ml, you are adjusting tidal volume with RR, you are increasing PEEP, you are doing a lot of things. All of these things that you are doing on the lung is going to affect the heart. All of the things you are doing on the lung are going to affect the heart. You are understanding this? That's why when you are doing any alteration on the ventilator, you must be mindful of what you are doing on the heart. Are you understanding? So the implications of this is that what I've shown over here is the same extracellular, intervalvular vessels. This is what the extracellular vessels. These are the extracellular vessels. Okay. So when you are at a lower residual volume, that is almost a collapsed lung, or PV ARDS, because you don't have too much of volume FRC here, your PVR is down. So it's your extracellular vessels. Extracellular vessels is contributing to your pulmonary vascular resistance. Okay, clear? As I told you, if we inflate the lung, where are we going to do? The intracellular vessels are having a problem. Okay, and then the intracellular vessels come into the play, which is contributing to the pulmonary vascular resistance, and that's why your PVR comes like that. So initially extracellular vessels in the lower tidal volumes, and then intracellular vessels, which then causes your PVR to combine and become like this. So this part of your story is ARDS. This part of the story is ARDS because there are low tidal volumes, the low FRCs, collapsed lungs. So this is ARDS. That's what the story is. Emphysema, COPD. That's the story is COPD. That's why it is highly unlikely that you have a patient in COPD and no PH. It is highly unlikely. It's highly unlikely that you have a patient of COPD or emphysema and there is no PH. कोई नहीं दिख रहा है हम लोगों को ये. समझ में आ रहा है? It's highly unlikely. That's why when the COPD feature comes, what is the PH? Perhaps will come in your mind. That's also the implications that we are ventilating these patients. That already PH is there. There is already PH, and now because of my heart-lung interactions, I will further worsen that PVR, further increase the pH and RV dysfunction. Are you understanding? Are you understanding this important principle? Okay. So this is the clinical implication. As I told you, the capillary perfusion is responsible for the maximum of the PVR. This is what this diagram is saying. The diameter of the capillaries are smaller, but that contributes to the maximum of the pressures. The smaller capillaries. It has got the maximum. This is the diameter, diameter. So the smaller vessels contribute to the maximum PVR. Capillaries. That means the intraalveolar vessels correspond to the maximum of your PVR. Right? Clear with this? Alright. So that's why you need transferring pressure. That's what I'm trying to tell you. That's why you need transfer to understand this. Now let's take the example of this thing. Okay. So this means there is one sweet spot where your PVR is the minimum. Where your PVR is the minimum, that is your sweet spot. This is FRC. In functional residual capacity, at that FRC level, what is there in your body, that is where your PVR is optimum. That is where optimum. That is where it is optimum. Now you decide to put this patient from FRC to 6 ml per kilogram tidal body weight, predicted body weight for your ventilation. This is what you're doing. When you do that, this is where your curve is going. Your PVR is coming here. So very small increase in PVR, isn't it? Very small increase in PVR. Now you decide, no, let me give him large amount of tidal volume. So what is going to happen? I'm going to 10. So when I'm going to 10, what is going to happen? A very large rise in pulmonary vascular resistance. So the clinical implication is don't distend. Don't distend. Ensure that your volumes are adequate enough. Over distension. Clear? And does that lead to problems? Does it lead to problems? Yes, it does. So if you look at this study, what is happening over here is this is plateau pressure and mortality. Okay, so when the plateau pressure is more than 35, the mortality is very high. Very clear. Plateau pressure is high, mortality is high. When you look at this study and you look into why the plateau pressure was high, this is that patients in which the tidal volume was 10 ml a kilogram. These are those patients in which the tidal volume is 10 ml a kilogram. So why did they die most probably? Because of? Because of?
pH.
pH means what?
Increased pulmonary vascular resistance.
Means what? What is happening?
Right heart patients.
Cor pulmonale. Okay, so they are dying because of cor pulmonale. You understand? These patients are dying because of cor pulmonale. Otherwise, there is no cause of death. No, it's not barotrauma. They are dying because of cor pulmonale. So this is the study that tells you that they can die of cor pulmonale, right? But all is not that bad. Okay, inflation improves left ventricular output, as we discussed. We discussed about the fact that transmural pressure is coming down. Didn't we discuss that? So it is actually improving the filling. Okay, because you are improving the IDP and all these things. It's improving the ejection and it is reducing the afterload. It is doing all of these things. So it is not all that bad. It is a mix of both that actually helps. That's why in cases of cardiogenic shock, you intubate them, there is going to be an improvement in left ventricular ejection output. and that is because of all these things. It improves filling, it actually improves ejection, and it reduces afterload. Are you understanding? Clear? Okay. Now to explain this is another study. Okay. So this means to say, if I inflate, the stroke volume should improve. This is what the entire thing is all about. If I inflate, the stroke volume should improve, right? So let's see. I am inflating. Okay, this is stroke volume here. This is baseline, and I'm going to inflate. This is my volumes. When I inflate further, see what is happening to stroke volume from baseline to increase. Baseline to increase. The stroke volume is actually improving. The stroke volume improves when you actually. So that's why when you are doing your ventilation, put your probe on the echo. We are doing echoes. Look at the echo. Look at your stroke volume. Look whether it is improving. That means you are doing fine. If your stroke volume is going down, means you have somewhere the problem is there. Either it is the venous return, or it is your afterload, or it is something that is causing the problem there. With that, you can understand whether your ventilation is right or wrong. You understand? Clear? So let us take the other example. You have a collapsed lung. So when you have a collapsed lung, as I told you, the PVR is going to be somewhere here. Now we talked about volumes, right? We talked about volumes. Now we are talking about pressures. Okay, I put PEEP. If I put PEEP, there is going to be a drop in the pulmonary vascular resistance if I give optimal PEEP. Okay, so that's why optimal PEEP, that is what we do when we recruit, right? If you have a patient of collapsed lung, we are recruiting these lungs, they reach a PEEP. Okay, when we reach the PEEP, the PVR actually goes down. The pulmonary, so you can actually judge your recruitment improvement by actually looking at your pulmonary vascular resistance or the afterloads, right? Or the ejection fractions, right? So recruitment, the PEEP is coming and improving the PVR. Clear on this? Now what happens if I decide, no, I just want to keep increasing my PEEP because oxygenation is low? You know, sometimes 8 ho gaya, 10 ho gaya, so I come and reduce it because I am seeing problems. I am touching, I am finding capillary fill going down, I am figuring out that the heart rate is going haywire. You might think oxygenation. For example, that patient, diffuse alveolar hemorrhage. That patient, diffuse alveolar hemorrhage, somebody put the patient on 12 saying that, he is not doing well, oxygenation is not improving. So I came made it 8, I made it 7 actually. I came with 7 because there were problems on that patient when I was looking at that patient. So PEEP is not all that good. So if I increase my PEEP, what is going to happen over here? If I increase my PEEP, there is going to be an increase over here, which is going to cause my pressures to go over distension, which is going to cause my PVR to go up. It can be counterproductive. You understand? That's why PEEP is very similar to the volumes, where it is going to cause improvement if you have done it well, but it is going to cause deterioration if you have not done it well. You must understand, this is a heart-lung interaction. Clear? Now this is extremely important for you to understand now. This is the last slide of the entire topic. Okay. Now here, what are we looking at? Your pleural pressure here, right? What you are seeing is your arterial trace over here. This is your arterial trace over here. This is your pleural pressure. This is your pressures inside the thorax. Okay, and what is going to happen? Okay, so this is what is going to happen when you are actually giving mechanical ventilation. I have given mechanical ventilation, so what is going to happen to the pleural pressure? The pleural pressure is going to go up. Pleural pressure is going to go up. And this is what we discussed in this entire so much time. What is going to happen over here? There is going to be increase in the RV afterload. There is going to be a reduction in the RV preload. We discussed all these things during this entire lecture. There is going to be a reduction in RV preload. There is going to be an increase in the RV afterload. We discussed this entire thing, and that will reduce your RV output. That will reduce your RV output, isn't it? That will reduce your RV output. This is what is going to occur. Clear on this? It will reduce your RV output. At the same time, what is also happening in this case, because of the squeezing effect of the alveolus is expanding, there is a squeeze happening. The capillaries are getting squeezed. So this blood is rushing into the left side of the heart. RV का ये problem हो रहा है, लेकिन left side में क्या हो रहा है? The blood is getting squeezed. So when the blood is getting squeezed from the capillaries, it is all rushing into the left side of the heart. It is rushing from there as the LV preload. It is rushing there as LV preload. And as we discussed, the LV afterload is coming down because of the transmural pressure changing. Right? And that is going to cause an increase in the LV output. So this is occurring simultaneously. Okay, this is occurring simultaneously when we are doing this. Right? Okay, this is occurring simultaneously. And that relates to an increase in the pressure here. LV output बढ़ गया, इसकी वजह से क्या हो गया? तुम्हारा pressure बढ़ गया, systolic blood pressure ऊपर चला गया. So pulse pressure has become wide. The pulse pressure has become wide. You're understanding? Now what is going to happen? The RV was less, having less blood. RV output was low, the RV is pumping low. So after a couple of breaths, वो RV जो pump किया है वही LV में आने वाला है. After a couple of breaths, so that's what transit is going to occur here. Okay, that transit is going to occur. That RV blood is now going to go to the LV. So that means after a couple of breaths, the LV will have lower output. They will have lower output, right? They will have lower output. And since the LV has lower output, what happens after a couple of breaths? You have a drop in your pulse pressure. You have a drop in your pulse pressure. So there is a change of pulse pressure from here to here, and this change of pulse pressure is called as pulse pressure variation. This change is called as pulse pressure variation. Okay, so whatever we do over there is PPV, or whatever we do over the PPV is because of this interaction that occurs, heart-lung interaction, which we exploit in different methods. Pulse pressure variation exploit different methods to actually understand fluid responsiveness. Okay, so those patients who have got higher pulse pressure variation are known to be fluid responsive. We are exploiting these heart-lung interactions to actually guide our therapy. Are you understanding? So this is how the clinical implication of that, of all these things. We are using it to guide our therapy. So in short, too many variation gives us an idea of fluid responsiveness. Too many variations gives us an idea. It can be stroke volume, it can be pulse pressure, it could be any of these stroke volume indicators. Alright. So this means the effect of airway pressures, volumes and cardiac loading and function is very complex. It is definitely complex. Underlying function of the heart and pulmonary vasculature you can understand because it is like a stress test. You can understand the heart is doing well or doing bad. You can understand that very well. Okay, why? It's because it's like a stress test, right? It helps in unearthing occult disorders. It's heart ischemias, heart this, you can actually unearth that. It helps us in guiding therapy. Just now we just discussed this, how to guide therapy with that. And to minimize detrimental interactions and preserving the beneficial ones is what we have to do. We have to minimize detrimental interactions, but we have to preserve the beneficial ones. Are you understanding? So that is the entire thing about heart-lung interaction. All right. Any doubts on this now? Any doubts? On heart-lung interactions? Anything about heart-lung interactions? So we have to use this every time we are working. The more you use it, the more you understand it, the more you understand what to do with your patient. If you don't know what you're doing with your patient, you might end up, like for example, you have a patient who's having oxygenation failure and you decided to dial up the PEEP. The PEEP is, you decide, oxygenation to improve नहीं हो रहा है, चलो PEEP और बढ़ाओ. Oxygen फिर भी नहीं improve, चलो और बढ़ाओ. What is going to happen at that time? There is going to be an increase in the PVR. RV dysfunction is going to occur. It is going to occur because it is not helping. So the beneficial ones are not working. The detrimental ones will have a problem. Couple of time this later, you will have the patient's blood pressure going down. You will have the patient not doing okay. You will have the patient's pedal edema coming in, body edema coming in. Patient not doing well because RV is not working well. Oxygenation is not improving. So in that patient, if you notice what happened in that patient, he was at a 12 of PEEP. That patient. And what happened? I came over there. I did a few tests myself to understand what's happening. And from 12, I brought the PEEP down to 7 directly. When I brought the PEEP down from 12 to 7, his oxygenation improved. Why would his oxygenation improve? Because I have removed the detrimental effects of cardiac output. Cardiac output has improved, oxygen delivery has improved, oxygen SpO2 improves. Are you understanding? So in fact, a drop in the PEEP over there actually helped the patient. Are you understanding? A drop in PEEP extra. So don't consider PEEP to be something that is very simple to use. No, it is very difficult to use. Okay, and the more complex interactions you understand, the more you will understand how to manipulate the system. You understand? If you don't understand it, it's a problem. Right?